I mean, I think it's totally demoralizing for people who I would normally look to be really quite resilient and saying, okay, let's just, we know this is a daily meal or whatever, but it's actually gone much deeper now. And I think the public just don't see, I'm sure you've seen that iceberg analogy where you can see the few things that we do, but underneath, like there's 100 other things being juggled at the bottom line. And I think, what it does, I think, is if we look at burnout, we say the word burnout, but what does it actually, when we actually mean is we are actually causing, if you look at the alcohol use on healthcare professionals, and I know we've looked at this, it's a way of, dealing with it. And you will see the increase. I would like to see the stats around the increased use of alcohol to deal with the current stuff. And we know that that has another effect on people's well-being.
Welcome to A Doctor's View with Dr. Polivios, a podcast discussing everyday topics in health, fitness, and mental well-being, as well as providing an insight into medical life and its challenges. Please note that all opinions of the host and guests should not replace advice from your own doctor. Now sit back and enjoy the show.
Hello everyone, welcome to A Doctor's View. It's been a while since we've spoken with our friends at Doctors in Distress, a charity which is dedicated to supporting healthcare workers suffering within the NHS and prevents suicide within the profession. I have three guests joining me today, all of whom are part of Doctors in Distress, to discuss the consequences of not looking after mental health of our healthcare workers, as well as the current GP crisis in the UK, and the fact that more healthcare workers are leaving the profession than ever before. So with me, I have Dr. Gavin McColl, a GP, Miss Samantha Anthony, an Associate Specialist in Dermatology, and Brenda Donnelly, a nurse who's also Primary Care Network Clinical Director. Gavin, Sam, and Brenda, hello and welcome to my podcast. Just working our way around, please just tell us a little bit about yourselves and your role within Doctors in Distress. So, Gavin, I'll start with you.
Yeah, thanks. So I'm a GP, I'm a partner of the Hurley Group. I have two sites. I'm the clinical lead of one in Peckham and one in New Cross. And I'm also the clinical director alongside Brenda, who's with us today, of the PCN in South Southwark. And my partner, Claire Gerada, and I were talking for a number of years about possibly setting something up that could support doctors. And Claire found Doctors in Distress had already been established, and we started working with that organisation, and we've grown it over the last couple of years now. My involvement's a lot is really as a trustee board member.
Awesome, thank you. And Sam?
Hi, so as you've kindly said, I'm an Associate Specialist in Dermatology in West Hart, and I've been in this role for about 14 years. I trained in both surgery and in general practice, and then essentially powered my way through a life-threatening illness where I had my first career break, then had a second career break that was in 2006, second career break in 2017 when I actually didn't work, had an opportunity to go to Canada, and I was actually at the brink of, what I would describe as burnout at that point. And it was during that break that I started to understand it a little bit more, and I essentially established the concept of committed to pause, which was born as almost a signposting website with information and ideas to share and encourage with other medics and healthcare professionals about prioritising self-care and understanding a little bit more about why we don't look after ourselves as much whilst we're caring for so many other people. And I put messages on Instagram about my thoughts and experiences regularly, and essentially I got in touch with Doctors in Distress after contacting Claire Gerada. As during the pandemic, I had a little bit more time to put into Committed to Pause, and so that sort of carried on, and we've become friends, and I've done a little bit more fundraising with them. So that's me.
Thank you so much. Thank you, Sam. And Brenda?
Okay, hi, thanks for having us here. I'm Brenda Donnelly, and I'm a general practice nurse in primary care in South Southwark. I've been most recently an education lead across South East London, And I'm, as Gavin said, a clinical director for a primary care network. And obviously, I'm much older than all of you, and I've been around for a very much longer time, and I've seen general practice change from one generation actually to the other. And so I was really delighted whenever Claire and Doctors in Distress was set up for other healthcare professionals, because as we all know, it's not just doctors that are in distress. Lots of our healthcare professionals are in distress as well. So it was great, and that's why I'm keen to get involved, because it's just awful to see our colleagues suffering in this respect and still having to give care to other people.
Thank you. And Gavin, and I know you're one of the trustees at Doctors in Distress. Would you be able to just give a broad outline in terms of what the charity does and its main focus and aim?
Yeah, exactly. As you say, Paul, it's a charity committed to reducing burnout, stress, and ultimately suicide amongst healthcare professionals across the UK. The three primary goals are to reduce stigma around mental health within the profession, to change behaviour and culture within healthcare around mental illness, and to promote the value of good leadership amongst the health system leaders. So Doctors in Distress provides support groups for people before they reach burnout and serious mental illness. The groups are online, they are UK-wide, they are professionally facilitated and are centred around supported reflection and conversations. And it's not therapy, but it being professionally facilitated means that if anyone's presenting with serious mental health issues, it can be identified and properly dealt with. It's an important aspect that we feel is independent from the NHS, so people can feel they can speak freely. It's confidential and safe, and it's, as Brenda said, it's for clinical and non-clinical staff groups as well. Our evaluation has shown that we've seen improvement in long COVID symptoms. Healthcare workers feel less isolated and better supported by their peers, and it normalises talking about how you're feeling, which is actually relatively unusual for healthcare workers. It's about providing space to talk about their concerns and their anxieties before these build up and reach burnout and other serious mental health illnesses. And we recognise it before and obviously during and since the pandemic, healthcare workers are not sort of the word designed to admit that vulnerability and to have these kind of reflections. So we have run groups for junior doctors, ITU teams, black medics, paramedics, those who are returning from periods of illness related to COVID, and address the anxiety related to returning people who have been returning, for example, who have been shielding. And with these groups reach, as I say, nurses and all allied health professionals as well as non-clinical groups. And we've even ran expressive writing groups as well for healthcare professionals. But one of our main aims is to change the culture within the profession, and we believe the best way to do that is to talk to and engage system leaders in primary and secondary care, but also to integrate these kind of interactions with medical students and foundation doctors, and we're building those programs. So one of the things we're really keen to do is to reach out to those groups, medical students and junior doctors, as well as system leaders, and try and get them to engage as much as possible in this kind of initiative.
Thank you. We've been speaking about burnout for quite some time, both obviously as the charity and also it's been known about for some time. But we haven't really spoken about sort of the actual consequences of it as it stands now, because I think, as Gavin was saying, over time it's becoming worse and worse, and we're seeing it come out in different ways now as time's gone on, and I think we're seeing different outcomes as a result of this. What's been everyone's experience with regarding to the increase in burnout and how it's showing its face?
I mean, burnout means different things, I think, to different people. I think the presentation of it is different. I think the coping strategies for or the recognition of it is obviously different. The support that people may seek or have around them is different. And I think that it may arise from issues purely at work. It may arise from issues outside of work that impact upon work. I've often said that the two are not mutually exclusive, they overlap, and inevitably one is going to affect the other. And the recognition of it, obviously, we're in a game where prevention is what we try and do, yet we're poor at recognising it. And if we do recognise it, we are, as healthcare professionals, certainly, perhaps I speak for myself, but we have this override button, which just can look past some of those little signs. Even if somebody is telling us about it, we still aren't, we might say, yes, we accept that, but we don't do anything about it. And I think this extremely strong sense of responsibility that we all have as carers it overwhelms everything, I think, and we almost feel that we can't step back from those roles even if we're feeling burnt out. Basic things like self-nourishing, having breaks, having really purposeful pauses is something I talk about a bit. It just doesn't happen because of the volume of work we have to deal with. And I think COVID and backlogs associated with it have certainly shown that to us. There's an awful lot of anxiety. We've still got targets to meet. And there just doesn't seem to be much of a contingency plan when people are, for example, having to be off work at short notice because they've had a COVID contact or have been infected with it. So all of this, plus delayed presentations, this is adding actually to the bulk of what everyone is feeling at the moment. So the presentations themselves are just wide, and sometimes we're not even in enough space with another colleague to see that that's happening to them.
No, absolutely. And with the permitted to pause that you've created, have you noticed an increase in people reaching out through that channel?
And it's interesting because what I have found with a lot of my observations and my own personal sort of experiences and feelings as we've sort of gone through the last 18 months is when I do put a statement or a topic that I then just talk about a little bit just in an Instagram post, the comments I've had back are so recognised. And I've had many people say, gosh, that's exactly what I think, that's what I feel. It's almost is being vocalised, and that's what's really important in all of this, and in a lot of the prevention as well, and looking after ourselves, is actually feeling safe to express it and feeling that, other people do experience it, of course they do, but I just think people are still afraid of this stigma, afraid of reaching out for help, afraid of being seen as being weaker, and by not by not sharing it, they're burdening that themselves.
Thanks, Sam. And Brenda, what's been your experience of the last, I'd say, year or so, really, with the increasing burnout and how it's showing?
I think, it's been quite profound, actually, when I look in our small organizations, and I think I'm seeing teams falling apart and people who had previously worked with one another having all sorts of pressures put on them from various different places. And actually, I know in one practice in particular, we have, like you said, there are other issues that are affected as well from outside. So we have to bear in mind that we have people who are childbearing age, we have women who are menopausal, we have all things that are impacting on people's well-being. And then when we have the pandemic and we have all this pressure put on different ways of working, completely different way of working that was previously there, I think it's put people on the edge. And I know, and certainly in a couple of practices very close to mine, where we have 2 nurses actually leave because they just couldn't cope anymore. And, practice manager completely stressed out. The sick leave I've seen is it's just phenomenal. And I think, oh my goodness, what's going on here? And I think, I remember when Gavin and I had chats when we were with the pandemic itself and setting it up. And I remember saying, being really vulnerable, thinking, oh my God, I think I'm having a heart attack. And actually, saying that, and it actually came back to me this week when someone said to me, Brenda, I remember when you told me this, and she told me now exactly what was happening to her. So this is someone else as well. So she was saying, I felt I couldn't eat for days and I couldn't do things. And I'm actually feeling this chest pain and all of those things. And I'm thinking, you're stressed. This is stress, you know. And the fact that she was able to say to me, because at the end of the conversation, she said, it's so easy to talk to you because you've been through this and you know what it is. And I think, yes, and I'm okay, I'm recovering, but it's actually being able to accept our own vulnerability, and maybe that comes with maturity or being older and thinking, well, I've got nothing else to lose and I haven't got any sort of badge to get anymore. It's okay, but I think there's a sense of responsibility there for us to make sure that we protect younger people coming in and saying, okay, well, these are the issues, and they don't have the kind of necessarily. General practices are very small, aren't they? They're like almost sometimes like an incestuous kind of relationship within there. And so you've got the partnerships and you've got the managers. And so when things are already under pressure, then it's like a melt. It's like a boiling pot ready to blow over. So it's how do we prevent that? You know, what do we do? What kind of things do we need to bring in to practices to help them to be a little bit more resilient? But I think that's huge that I see so many people, and then people retiring early when we can actually use that skill.
It's interesting the point's been made about the crossover between working life and actually your home life as a result of the burnout. And it's almost like people can cope to some extent with one side of aspect, but it does actually lead to problems in all aspects of life. Just spending so much time in the hospital, the stress that you have at work. And in Gavin, with regards to, you work very closely with Doctors in Distress, and there is the darker side of burnout, which does lead to suicidal thoughts, suicidal ideation. And we have seen, obviously, as the way the charity was founded, that suicide is something that can happen and sadly does happen. What's been your experience within the charity over the last sort of 24 months in terms of any rise or any extra calls for help regarding it?
Well, the charity, as I said, is about trying to get there before these levels of burnout and stress happen. Like you rightly said, the founder of the charity and our trustee sadly have lost close family members to suicide. And listening to those stories, it's so powerful. And listening to Claire and the doctors working within the practitioner health program that is designed to pick up on those serious mental illnesses, and there's a significant increase in people presenting to that service. It's really interesting to hear Sam talk about it, and Ben touched on as well, the carer role, this understanding of what that means, and this sort of increasing responsibility. And then, Brenda, you mentioned the fact that the sudden changes we have as well in the way we've been practicing. I think it's a real shock, isn't it? The way that you really get used to doing something and then suddenly it's all been completely disrupted. And the lack of these small units that general practices are, that they can sometimes lack that wider resilience. And the burnout we're seeing, as Ben is saying, we're seeing it everywhere. And it's little signs that you see often. Practice manager came to me today actually and said that he saw two very senior GPs over the last week visibly shaking at the end of their clinic. Just physical signs, as Brenda was saying, just not coping with the demands that are coming on, because there's not very clear boundaries either in healthcare, and particularly in general practice. The work just keeps on coming. People go off sick or the work increases. You're just expecting to pick that up, and that's a really, really unhelpful aspect. And then you get this kind of runaway train effect, don't you, where people get sick and then increased demand, and then people go and become locums, and then the locuming approach, you're more isolated yourself as a locum. I think you're not plugged into a team as much, and in the team itself, there's things that locums don't pick up on, so there's more demand left on those team members that remain.
The GP comments actually very interesting. Obviously, it's been a big headline in the news recently. The wait times and the accusations of not seeing patients face to face, and everyone who's sort of within healthcare, works within healthcare, knows that's a very skewed headline, as it were. And I think we all know there's far more reasons and that GPs are seeing patients. And I just wanted to ask, Brenda, you might be able to shed light on this in terms of what's headlines like that doing to the current morale in general practice and just the burnout situation amongst GPs.
I mean, I think it's totally demoralizing for people who I would normally look to be really quite resilient and saying, okay, let's just, we know this is a daily meal or whatever, but it's actually gone much deeper now. And I think the public just don't see, I'm sure you've seen that iceberg analogy where you can see the few things that we do, but underneath, like there's 100 other things being juggled at the bottom line. And I think, what it does, I think, is if we look at burnout, we say the word burnout, but what does it actually, when we actually mean is we are actually causing, if you look at the alcohol use on healthcare professionals, and I know we've looked at this, it's a way of, dealing with it. And you will see the increase. I would like to see the stats around the increased use of alcohol to deal with the current stuff. And we know that has another effect on people's well-being and their physical well-being as well. So, and I know anecdotally from my colleagues that lots of people are really struggling to not have alcohol at the end of every day. And, what are we creating? We're creating more addictions and, that kind of beating yourself up as if, Sam, you were saying about, we feel that we keep having to do more and more and we're almost superhuman. And actually we're always looking to find the solutions and we don't actually find the solutions for ourselves. We're just, it's just keeping creeping up and creeping up and creeping up. And I've seen so many of my colleagues now as GPs in tears and thinking, what can I do? And I think, patients, when you see them one-to-one, they say, oh yeah, we know we're working. But it seems when it goes outside, well, it's not there anymore. It becomes a collective other. So we have to be that group within ourselves as healthcare professionals to hold ourselves back and say, hang on, it's time for me now. But that's extremely difficult. It's extremely difficult for many of us. And I've told my colleagues to go home and go and look after themselves. But I think we have the added problem within general practice because GPs are employers in partnerships. And so not only have the responsibility for their clinical practice, but they also have the responsibility for employment. And when you don't have staff and people are going out, then it becomes an added pressure, doesn't it? So it's a really, really difficult, and they've been brought up with, yes, the doctor will serve it, will do everything. And it's just an impossible ask. And I think that morale has just sunk to and I've been in general practice now for 30 years and I've never seen it so bad. And never have I thought for myself, actually, I think I might take early retirement now. And, I thought in 2003 when I was a partner within a general practice. And I remember thinking at that time, actually, what would make it better when partnerships themselves sometimes are a bit difficult to maneuver and everyone's got their own idea of what's what. And I'm sure we know about partnership splits, but I think right now I worry how they're going to hold this together.
Thank you. We've spoken in previous episodes about burnout with Amendip and also with other experts in the field of burnout. We spent a lot of time discussing what symptoms you get in terms of on the lead up to before it becomes a problem. And I think we all came to the conclusion that there's very subtle signs that build up and up and up until the point where you do start calling doctors in distress or people do start taking notice. And I was wondering, Sam, do you have anything to add in terms of the little things that can happen in a day-to-day life within the hospital or even outside of the hospital that people can actually start to think this might be something I'm suffering with?
Yes, I mean, as you say, it starts very subtly, and that's why it goes so unnoticed in yourself and from others as well. The very recognised things, and I'm happy for Gavin, Brenda, you to chip in, but a lot of the recognised things are, stop being anxious about something that actually was probably a lot smaller becomes a bit bigger. Your problem-solving skills just become a little bit more like treacle. the ability to prioritize and really put some of those things at the bottom of the list or chuck them out altogether. I think then, some of those other physical things, you sort of feel tachycardic sometimes, you feel nervous about, again, doing small tasks, or even where you are more comfortable maybe speaking publicly, you then find it difficult doing a presentation. I think sleep starts to get affected. I think, you start to worry about other things that weren't even in your brain or on your list to worry about. Perhaps I say all this from previous experience, but we all feel this at some point. And of course, being anxious and having these little worries, that's all normal. We all do stressful jobs. This is real life. But I think it's recognizing at what point you sort of tip over that edge and it starts becoming less okay and more of a problem. I think at work, I just sometimes the communication you have with people changes as well. I think some people either sort of retreat a little bit and just don't speak up. They don't volunteer. They don't really become part of those conversations and discussions. They hide away. And then other times it can sort of come out a bit more abrasive or just short-tempered, and then all the jobs you're trying to do, you sort of feel like you're doing them less well. And again, it's just that feeling of overwhelm. So it could be volume of work affecting that, but it's all those other feelings that make the little tasks much harder. And I often talk about a bowl of spaghetti, like it just feels sometimes that overwhelm where you literally can't see one strand from the other. And actually what you want to do is just peel out each little strand of spaghetti. It has a start and it has an end, and you can line them all up and it's much clearer. But it's not like that in our heads when we feel sort of overwhelmed and beginning to burn out a little bit. So yeah, those are some of the things that I can reflect on.
I think that's brilliant how you described that. Yeah.
I can imagine what the symptoms and signs and things you can see in the hospital setting, in terms of when you see it in a colleague and you're kind of attuned to it. In a GP practice, you're, as Brenda was saying, you're quite isolated in a way. Yeah, and I remember just from my F2 rotation many years ago, having a 4-month block, and you were, for the first time, I was in a room with no one else, and you've got some MSN version of MSN Messenger or whatever it was at the time, chatting to someone. But how in the GP practice, what are the other subtle things that you might notice in a colleague?
I think what's so interesting, what I was saying there, was the approach to it, because some of the really obvious ones, the kind of palpitations, the inability to deal with the clinical workload, these are kind of late signs, aren't they? And you need to try, like you're saying, you need to really get into the kind of the more subtle signs and know, and the way you spoke about it was perfect, and know when it becomes a problem, because obviously it's normal sometimes to be a little bit anxious and to get a little bit irritable and to get a little bit, to have problems at work, but it's knowing when that crosses over. I think that is about relationships, isn't it? And as you said, it's about looking at how people are communicating, how they're relating with each other, and I think unusual things. I think if you know each other, and this is what's so good about being part of a small team. If you know each other, some starts just unusually behaving. So I think that spring to my mind is people complaining of eye pain, eye strain, finding clinical cases that they would normally find okay, coming and discussing them and feeling and spending long periods of time dealing with not simple cases, but things that they would normally been okay to deal with. And this irritability, I think you mentioned it as well. You touched on it. And difficulty with relationships outside as well, and you do see that, don't you? When you know people closely and you're working in close knit teams, you can detect it, but also you know it through those conversations. It's just taking a minute to just ask someone how they're doing, isn't it? And just saying, how's your wife? How's the kids? How's things at home? And having it not be a cursory thing, actually waiting for the answer properly. I think that's, for me, the way to try to get these early detections and to increase the understanding of when it's crossing over into being a problem.
Yeah, I think even from personal experience, I've found sometimes asking people twice, because we all ask people how you doing? You okay? And it's very easy to dismiss the answer because most people will say, I'm fine, I'm okay. Sometimes actually taking the step back to say, is there anything you want to talk about? And almost being very blunt about it. And I found that to be quite helpful. And it's amazing what people can. I've done this with patients actually, and it's amazing what they will tell you on that second ask. So it's just something that might be worth considering for us.
I agree completely. I think, sometimes we're too quick. We're looking at solutions before we start. If you just put the emphasis on how are you today, then the individual knows actually you're inquiring, you're curious about me rather than, oh, how are you? It's just a pleasantry in the day. And I think, that gives people time to speak. And I think, when you're talking about the other burnout signs and what else we're looking out for is normally people who are quite jovial just turn into themselves. They don't get involved anymore. The people who would volunteer normally to do things don't volunteer anymore. And you just, they're so just tiny little things that you think, oh, there's something not quite right there. But I think then we haven't got within our work atmosphere, our work situation, somebody just to go to. Like people go to occupational health and other jobs, or they go and see somebody else. We can't really see anybody. And in general practice, if you go to the manager, then they're worried, oh my God, somebody's going to go off. So it's that kind of, where do we sit within our employment as to what we're going to tell anybody in the first place? Or what if, how do you do? It's a real tricky situation in general practice, really. And to be vulnerable and to say that there is something wrong.
A common theme that seems to have happened is, even though the awareness of burnout is there amongst GPs and amongst people in the hospital, doctors and nurses and other healthcare professionals, as you say, there is this reluctance to step forward. And I think there's been this idea and this stigma around it that it's going to affect your progression or it's going to affect your career in some way. And Sam, I know you mentioned you've had personal experience in this, and is there anything you can shed light on that in terms of that, it's okay to not be okay sometimes?
Totally. I mean, I think my career break that was completely opportunistic because my husband got a job abroad at the time and the timing couldn't have been better. But of course, I completely stressed about what do I do? How do I leave this country? How do I leave my job? Actually, I thought I was, not going to do it. And I thought this is the only opportunity I'm going to get. And actually work supported me going. And had my job for me when I got back, I couldn't have had better support. But actually, the permission side of things was quite major. And I think that's why I focus on that a little bit, is about how much we allow ourselves to do these things, or don't allow ourselves to do these things when whatever it is, it doesn't have to be necessarily a 9-month career break, but the small things like a break at work, just to take 10 minutes to go and get your lunch, to go and get a drink of water, to just have 10 minutes to offload with another colleague. You constantly feel, I think, in those situations that there is definitely a fear of judgment. There's a fear of someone thinking you're not working hard enough. Actually, no one's judging you really except yourself. And I would definitely say that having a career break was the best thing that I could ever have done. Whether it was then or another time, it was a total opportunity to just reset and just to reflect, but also look at how things could be different after this. And I think over time, I really lost guilt. And I think that's another major kind of feeling that a lot of healthcare professionals have, is that guilt that you're caring for yourself, which is so ironic. It's so utterly ironic. And I think there's also a huge fear about consequence. I think there's a fear of letting a team down if you're not there, or I don't know. Obviously, the biggest consequence is doing something untoward that affects the patient outcome. that's clearly our biggest responsibility several times a day. So all of those things kind of add into the pan. But I also am aware of a couple of other sort of situations. I've just heard from a friend recently who works in Ireland as an anaesthetist, and they've introduced a career break between, I think, the second and fourth training years, she was telling me. And it's been received really well. And that's been given to them as an opportunity. In Australia, there's a sort of mandatory, actually, I don't know if it's mandatory, but I think they absolutely put in X number of years down the line, say after 5 years of service, you have this amount of time off. And it's highly encouraged. And I think this kind of thing, if it's made a bit more open and available and an opportunity, things like maternity leave are done well, they're planned, you can take time out for a period of time, and actually a break for however long that you feel that needs to be, if that became part of what we do as part of our working life, I think we might keep a few more good people, people in the profession, just knowing that there's some idea that we are being thought of along this long journey that is a very hopefully long, healthy career, and for the better good of our patients as much as ourselves. Essentially why we went into it, but not at the sufferance of our own health. I think that's something I've learned on more than one occasion.
I completely agree. If someone said to me after 5, 6, 7 years, I've been working for I think close to 11. If someone says you can have a time off and it's part of your rota or it's part of your career, I can see a lot more people staying. Actually, personally, the problem is the staffing issues, and this is where we're at the point where it's this catch-22 in that people are leaving because of the stresses, burnouts, yet the things that we need to do to help prevent it are going to inadvertently cause other problems, and it's a real difficult situation. I don't know, Gavin.
I totally agree. I mean, I think when listening to you speak there, it was, for me, I've always thought it's about systematizing or putting into the system space and time. And listening to Brenda as well, she's saying about how can partners, and you're saying about asking twice. It's just about making it in the system, in your process. You have to build in space and time. Now, whether it's a year every 5 years, or 6 months every 5 years, or whether it's 5 minutes every day, or 20 minutes at your weekly meeting, and that's what we've done in one of the sites I'm running. It's a standing agenda item, workforce pressures, and we spend the time. So it's not someone having to complain about it. It's part of the system, part of the process that you have. And can I just say as well, when you mentioned the media challenge, and Sam's mentioning about about guilt, and I think the answer to the media challenge is it really hurt. Is the thing. It really does hurt, because people do feel guilty, and then they feel like they have to work more and more and more to try to satisfy that guilt. And I think it's a really dangerous thing that's happened, actually. Carol.
Oh, sorry, I was just going to say sometimes.
No, please.
We define ourselves by our roles. And so therefore it is really difficult to come out of that, because you're supposed to be that person who can do that. And, I couldn't agree more with you, Sam. I have taken my 3 pseudo maternity leaves. And it's the only reason why I'm still doing this job. I don't have any children. And I think, why should I have to work all my life in doing the same different people? I think I used to be jealous of women went off on having maternity leave because it was a break, but actually they had to do 2 jobs at that time and then left thinking, oh, I'm never going to be able to come back to work again. But in actual fact, if you never go off and do nothing. I mean, I did garden design and horticulture, which gave me a completely different scope and things. And I thought that was just fantastic. So I come back completely refreshed, completely looking at things from a different perspective, and think, actually, you're going to gain far more from that. And you've got far more joy in your work as well. And you can understand people a bit more because you make comparisons to what other people do in their day. So,
And having worked with you, Brenda, I know that how that's changed you, what you brought, because you quite often will bring gardening analogies in, and it just shows that having those experiences just enriches the overall team. Sorry to talk about you.
Sorry, but I think we need to look and not be defined by the medical or the nursing role that we do, because it puts us in a box almost. And if we can get outside that and get 3 months doing something different or in a different, I mean, look, we can't even move from general practice into hospitals, can we? We're in this system where we don't work across with each other. So, we're really already boxed in many ways. And taking us outside that and giving us something completely different. I think women have it luckier, maybe young men now as well, take much more responsibility with childcare. So it must give them a kind of different slant on how they practice as well.
And I would still say, time and again, that a planned break is better than an unplanned one. So, it's losing that member of staff at short notice because of burnout or because of illness or because of being demoralised or because of early retirement. You don't want that. If it's planned, it's a much better situation for everybody.
We've spoken obviously quite a bit now about the signs, symptoms, and all these things in burnout, and we've done all these episodes on it. One of the difficult questions, which has been very, very hard to answer, is what do we do about it? Because it's getting a lot worse. And I know we've had the discussions in terms of things that might be able to happen in the future, but these are things that are gonna realistically take some time to implement. And I don't know what your thoughts are on the now, as it were.
I think it's space and time. You've got to give people, I say if it's short, you have to, and you have to change. But in order to provide that, and provide the right kind of space and the right kind of culture, I think you have to change leadership. And it has to be, like I said at the beginning, our approach is to look at students and junior doctors as well as leaders. It has to be a sort of bottom up and top down approach to change the actual culture within the workforce and within the profession, so that people, because the health professionals are not different from anybody else. If they're given time and space, they will act like other human beings, and they will answer those questions normally, and they'll say the truth, and they'll say, actually, no, I'm feeling tired, I am feeling like I'm not coping now, actually. It's just kind of conveyor belt, it's kind of push. It doesn't allow for that. I think these need to just create space.
I think there's also so many other things that I feel can really be just cut down a little bit. So if you notice with trainees now, and just the curriculum, the way that things change in different specialties, and just the number of hoops that have to be jumped through, be it doing so many audits, doing so many appraisals, doing so many of this, that, all these things. And at least personally for me, I find it overspills into my free time, my normal outside of work. No one gets paid to do these things, and this is hours and hours of work. And if I was in charge, I would literally cut that down to a third of the amount of stuff that has to be done. And I know people argue, well, they're needed for these reasons and for research. I could argue against that personally, but I don't know what your thoughts are on that. Sam?
Oh, I feel strongly about that as well. It feels like, again, the volume, we've talked about the volume of work we have at work. It's all the other stuff. And that is additional volume. Where does that get fit in? It does get fitted into the time that we actually don't have. And time is a massive thing in all of this. I think lack of time puts pressure on so many aspects of our life, at work and outside of work, and we can't make it. We can't store it. We have to make the best of it, and we have to just find ways of, again, perhaps it comes back to prioritising. But unfortunately, those tick boxes that we still continually have to tick for the annual appraisal, like you say, we could probably do a lot more things that we're really interested in rather than ticking the boxes to do them, and still get to our appraisal. And I'm not diminishing at all the importance of us needing to keep up our CPD, obviously. But realistically, it's hard for us to understand how to fit that in. Therefore, how can we actually expect a patient who sits opposite us, seeing that we're under pressure and stressed and, now consulting for 5 minutes instead of 50, routine. That's the other stuff that's all going on in the background. For them, they don't know that. We're the only ones that sort of know what we're having to deal with every day. And so, I totally agree with you. This could be way better. And I think, and that does have to come, I guess, from higher bodies to look at that and understand the pressures that has upon the workforce. It's hard enough doing the job every day at the coalface on top of everything else.
Yeah, it was interesting how during the pandemic, when everything was, up in arms, and how all of the bureaucracy just kind of went out the window, and it was a case of just get things done, and everyone kind of just ignored or they were just told not to bother. People were coming back to work without any appraisals whatsoever. People coming back out, from retirement because we were short staffed, and it's funny how all of a sudden all these things didn't matter. What mattered was you were a good healthcare worker and you were willing to work, and we did our best with that. But yeah, Brenda, did you have any thoughts on that?
Absolutely. I mean, I think the stuff that we have to do is total waste of time. And I look at it and I think, in the name of the good Lord, where's the common sense? If we spent that time having a relationship with each other and saying to one another, actually, it's okay that you don't know that. I'll tell you what it is, or I'll give you a man what can. It's those real practical things. And I think if we spent more time enabling each other to say, I don't know this, I'm not secure about that, can you help me with that? Then I think we would give better care to our patients and would be much kinder and humane to each other as well. Sitting behind, I look at them and I think, I am not doing that again. That, governance and guidance and I can't even remember what the analogy is, but it's about protecting the patient's confidentiality. How many times do I have to do that? Do I have to do that every year? And I think, I know what that is. Innately, I know what that is. I think what we need to do is instill that kind of common sense approach to people rather than having to just follow scripts. You do this. There's a load of things on Blue Stream. And the practice manager sent me the stuff and I'm saying, I'm not doing that. I'm not doing it. And I think, I feel sorry for younger people because I think you just do what you're told. I think we need some sort of sense of actually stand up here. I know what I'm doing. I've been to college. I've done my medicine. I've done nursing. I've got a voice here. And I think that's where the clinical voice came in, Paul, when the pandemic. And I think what's really shown to me, I was responsible for setting up the vaccination service. Who came in first? The retired GPs. And who enjoyed it the most? The retired GPs. They all loved being part of the MDT and part of this thing that they could get on and do the job. And they were worn out with people telling them what to do. CCGs, FHSAs, health authorities, how many structural changes have we had? Countless. And I think, we I don't know how we're going to do something about that, but if we could reduce that kind of level of training, then I think it's a kind of mistrust. It's all building up there so that we will prevent litigation. And it won't. It won't. It won't.
But if actually, following on from what Brenda said, if actually there was mandatory training in that big long list of fire safety and manual handling about the signs of burnout, about what to look out for, that does become something that is instilled and that is recognised. And every year, if it is once a year, maybe it should be every month, but that would make much more sense. And then people might recognise it and they might say it's okay because this is being recognised as being something important, as important as fire safety. So,
yeah, absolutely. If that was part of the mandatory training, I think it would be the most useful module there, to be fair. But Gavin, sorry, I interrupted you there, sorry.
No, well, I mean, I totally agree, and it's interesting when you think about when you mentioned when you remove these mandatory aspects that, and Brendan and I worked together at this time. Relationships really grew very quickly, and innovation happened a lot quicker. So they really are barriers. These things, they actually act as barriers to progress, and they don't really serve much, as we're all agreeing. It's frustrating.
Yeah.
And Gavin, when you think about what we did at those days too, so we had a lot of people in who we didn't know what they do. There were new people coming in, but what we did do at the beginning was do a brief and a debrief. And so,
Mm.
5 minutes at the start, 5 minutes at the end, and bring in some food or whatever. It made people feel valued, but also it was okay to make mistakes. And when people like me or Gavin, we said we'd done something wrong, it was just made it so much easier for other people to do the same. So I think it's those tiny little things. I think if you had a huddle in a practice, or you had a huddle with people and you said, okay, 5 minutes, let's go out and have if you travel through Asia, you see people out all the time doing yoga and doing things. 5 minutes outside, fresh air will do us the power of good. It'll take us away from that kind of terrible positions that we sit in as well all day long in general practice. That can't be good for us either. So I think there are lots of little things you can do, and there's a really good app called Shiny Mind, which has been funded by NHSE originally, and it's kind of like, how do you do meditation on three fingers? Telling yourself, I can do this, and just those tiny little mindfulness moments that we could sort of implement, and help other people get involved with it as well.
I remember when I was at med school, we had what was called baggage seminars. And this was the most disliked, hated, protested thing that I think I've ever come across, to the point where I think we even signed a petition to get rid of baggage seminars. And they actually got rid of it because it was getting a bit ridiculous. And it basically involved once a term, so 3 times a year, you got into your groups, and it was about, I think, split between about 40 people per group or 30 people per group. And you went into a room, and there was a facilitator, and you were around in a circle, and you took turns to say and debag and to say things that were on your mind. And so a bunch of 18, 19-year-olds in a room trying to express your feelings and what you've seen in the hospital. It didn't work very well. But now, all these years down the line, you kind of appreciate what they were trying to do. I think it was a wonderful concept in theory. I think the way that it was executed, because it was such a new concept then, was not done well. But I like to think that if it was adapted a little bit to modern day life now, I think it could be something that med school should, if they don't already, offer for upcoming junior doctors and nursing students and the like.
There's an interesting relationship there, wasn't there, between mandating or kind of making it happen, and then how people react to it, and it can be quite tick boxy, versus saying, look, whoever wants to come to this can come to this, and that's what obviously doctors in distress is like. But the problem is that those who are most burnt out are probably least likely to be able to make the time to go to a burnout session. So there's this difficult place.
But I also think sometimes, obviously group stuff is great at that sort of age. Maybe they're not volunteering for it much as you didn't. But I think a really simple measure would just be, even just to buddy up with somebody at work, that's made a thing. Because that is a really easy opportunity to do it with somebody you know, that you do it regularly, you check in with each other, that person is checking in on you. And retraining in counselling, you have a mandatory mentor. That person is the person that you offload to regularly. And it makes me remember that sort of when you hear about counsellors, they have somebody, they have to share it with them. And I don't really, neither of us could understand when we're talking about it, why this doesn't happen in medicine. Because that is a really safe, easy way of doing it. And it costs nothing. And we could be doing that now at work. It doesn't, I think it would perhaps identify those people that aren't reaching out for it as well.
I think before we wrap up, there was something I wanted to just ask very quickly on your opinions. Something that was brought about from the discussions we've had with webinars in the past with Doctors in Distress, and it's this idea of, over the recent pandemic, the NHS staff have in a lovely way, been labelled as heroes and having these lovely accolades. I've had mugs given to me and, stickers and T-shirts. And there's this thought that being given this sort of title of hero, actually putting more of a burden on people, even though that's completely not what it was meant to do. But because heroes don't have problems, so you're less likely to come forward with something. And I was just wondering what your thoughts are on that. Maybe Brenda, do you want to?
I can see where you're coming from, and I suppose if you're asking someone like me, I think I've been really lucky because I've had clinical supervision for many years. I make sure I get somebody because that's what I need, and I'm good at expressing what I want for myself. But I think, yes, there is, if you're made out to be this icon and you're the wonderful person. But I suppose with nurses, I think we don't see ourselves such as heroes. I think, they're very kind of, well, we just do the job. They actually underestimate what they do. So I think it's more an issue of we need to raise them up and say, you're doing an absolutely amazing job. I think we often have this kind of underlying, we're just nurses, which is absolutely ridiculous. And I think, in many ways, they suffer from the other end of that.
I was actually speaking about imposter syndrome a few weeks ago, just about that very thing. This thought that, people just think that they're just this, and, it's so far from the truth. And I think that in itself could potentially be contributing to burnout in its own right. But no, thank you. Gavin and Sam, any other thoughts at all?
I mean, I think it's unhealthy personally. I don't think I don't know many people who it sat well with at the time. I think it felt a bit, like I was saying, it was obviously coming from a good place. But there was, it's a bit of a sort of cliche to respond to, you're just doing your job, but it is just a job, you're not. And it sort of almost denotes and suggests that there's more. And obviously it's a great job and it's a wonderful job, and the hard work you put in, you typically do get back in reward. So I think it is unhealthy, I think. And I've got a little boy and he's into superheroes, and you've got heroes and you've got villains. And I think that the minute you've got a hero, you're going to have a baddie. And I think sadly that's kind of what's happened with the media, in the sense that there's heroes and now there's the baddies, and it's GPs. I think it is an unhealthy oversimplification.
I guess we don't see ourselves, because the heroes have been the people in the hospitals, hasn't it? You've been the ones who've been doing all of this. Oh my goodness, all we see on TV was these pictures of doctors in PPE, whenever in general practice we didn't even have the PPE. We were there without any kind of safety, without any kind of stuff at all. So we certainly didn't see ourselves as heroes. We were actually, I felt that we were neglected, and we would have been at the bottom of the bunch, really.
But that's the point about guilt, doesn't it? You mentioned earlier on. So if you're a hero, you've got to be there. What does it mean? You've got to be an ICU doctor. You've got to be. If you're not, dealing with COVID every day, then you're suddenly not a hero, and you're guilty. Or if you go on holiday, or you take a week off, or if you're not coping, you need to take a bit of time to rest. It's just an unhealthy narrative, I think.
I completely agree. I think it creates a huge expectation, I think. And as you both said, this is a job. It's more than any old job, but it is a job that we have chosen. It is a vocation, and we've taken on the chin everything that has gone with it, including the risks to our own health. But maintaining that, it is not sustainable in any form. And I think this is the work that we do, that everybody does, doctors, nurses, everyone in the health system is doing every day. But when it was put then in the media and people were frightened, and they were watching this and thinking, oh my goodness, how are they doing this? This is what they do. It's just they're wearing something slightly different, dealing with obviously a massive new impacting virus worldwide, but no one's running away from it. And again, that sense of guilt that people who couldn't be in it, they couldn't be on the front line, they had to shield, they couldn't be at work for whatever reason, that came into it. So this overwhelming sort of expectation is very burdening, And I think no one's gone into the profession to be constantly praised. A little bit of acknowledgement is nice, but no one's gone there to be on the stage and be up in lights. But they've also not gone into it to be criticised. And I think I will admit that at the beginning, I found it quite emotive. I was really proud to be working on the NHS. That, I was on ITU, but oh my goodness, I felt proud of what we were trained to do. And then it carried on, and then it waned, and then it turned from, clapping into quite a lot of anger. And we all felt that, actually. Certainly, secondary care and primary care, across the board, we felt it. And now we're just sort of trying to sweep that up now and decide how to move forwards and make it all better again. But is that all down to us? I don't think it can be. We've got to all still work as a team. Literally, we're all part of a much bigger picture.
Yeah, thank you. Thank you all for joining this evening. It's been absolutely lovely chatting to you all, and I hope we can actually meet non-virtually at some point. That would be lovely, and actually have a proper conversation in person.
Thank you. Thank you very much. Thanks for inviting us.
Pleasure.
It's lovely to chat to you all.
Thank you all for listening to such an interesting discussion, and I would like to thank again all our guests for taking part. I would like to also direct your attention to the podcast description, the show notes, and just have a look at the Doctors in Distress website, but also Samantha Anthony's website, permittedtopause.co.uk. I've left links for that one there too. And that was created to reach out to doctors and healthcare professionals to encourage positive changes to their well-being and also share an understanding as to why self-care is so important in the profession. So with that, I will leave you and I'll join you again next time. I'm Dr. Bolivios. Goodbye.
Thank you for listening to A Doctor's View. If you're enjoying the show, please don't forget to subscribe or follow on Apple Podcasts, Spotify, Google Podcasts, or your favorite podcasting platform so you don't miss a future episode. If there are any topics you would like considered for the show, please get in touch via email at adoctorsview@gmail.com or visit adoctorsview.uk. And be sure to follow the show on Instagram at A Doctor's View for some behind-the-scenes posts. See you at the next episode.